I am Ronnie Shore, a board member who will be acting as your moderator. So tonight we're going to be talking about how racism how creates health inequities. Bob Lutz, who's a medical director or medical advisor on COVID-19 with the Washington Department of Health. He has worked most recently with the Spokane Regional Health District before moving to the Department of Health. And then Heleen Dewey, health equity specialist with the Spokane Regional Health Department, will be joining us also. And she focuses on racial equity in her job and on providing and focusing on better health outcomes. She's a member of the Turtle Mountain Band of the Chippewa Indians and is also a Santee Sioux. Amber Lenhart works with on the Health Impact Project, which is a collaboration with Robert Wood Johnson Foundation and the Pew Charitable Trusts. And she also is a health policy specialist with the Spokane Regional Health District. So remember that you can also ask questions of our speakers, put them in the chat, and Gary Goldbaum and Hal Stockbridge will be monitoring those questions, and we'll follow up the presentation with about 15 minutes or so of questions. You can add them now, and we'll prompt you to add them later as we're going on. So now, Bob, why don't I let you go ahead and get started and share your screen.
Are you seeing that, Ronnie?
I'm seeing it.
Okay, great. Thank you. And the last thing you want to do is see me. And so I will turn off, well, maybe I won't turn off my camera, but good evening. And thank you for the opportunity of talking with you all this evening. And I'm talking to you from my basement in Spokane. So bear with me, the backdrops, nothing very fancy or innate. So let me see if I can, I'm never really good with this technical stuff. So anyway, next slide. So I typically will start my talks with the definition of public health, which I, again, pull from the Institute of Medicine from back in 1988, that says that public health is what we as a society do collectively to assure the conditions in which people can be healthy. You know, so again, I emphasize the words as a society. It's a collective responsibility for all of us. And again, importantly, it's the environments in which people live, work, live, and play. So public health focuses on the root causes of what makes us healthy or unfortunately unhealthy, i.e. the conditions. And these root causes run deep and long. They're societally and socially constructed. And unfortunately, it favors many members of our community rather than others. And I think, you may have heard this statement a couple of years ago that your health is more defined by your zip code rather than your genetic code. And so things such as educational attainment, socioeconomic status, structural poverty, residential segregation, and public safety, these are just but a few of the societal and physical factors that impact health along our entire life course, from conception to death. The nation's disease burden is increasingly attributable to behaviors shaped by these social determinants of health. So the outcomes of these determinants of an individual's and a community's health are many. Environmental injustice and systemic racism, homelessness, food insecurity, substance abuse, suicide, domestic violence, injury prevention, firearm-related violence, reproductive rights, and climate change. These are but a few that the American Public Health Association defined as within the wheelhouse of public health professionals. Health equity, with the slide that I just previously presented, again, it's all people having the opportunity to attain their full health potential. regardless of their social position, their race, ethnicity, their income, education, gender identity. And my computer just, yeah, there we go. Sexual orientation, disability, or other socially determined circumstances. And this is again from the American Public Health Association. It defines the 10 essential public health services. And it's a framework for which public health looks to protect and promote the health of all people in all communities. And importantly, this past year, they put equity at the center of this framework, which again, I think is really important because fundamentally, we need to acknowledge the fact that our society is one that is not equitable for every member of our communities. So this is just a graphic, and it demonstrates to you the fact, what we call social determinants of health. And although historically in medicine and much of behavioral health, so public health, we focused on risk factors and those things that we do, the reality is that much of it is socially and environmentally constructed. And so as you can see from this graphic, healthcare, those of us who are in the healthcare field, we have to acknowledge that our impact on the overall health of our community is but a small percentage of the total of what really impacts our community's health. Socioeconomic factors, which I mentioned before, health behaviors, which are again strongly impacted by those socioeconomic factors, those social determinants of health. And I think the important thing for those of us who are in healthcare to realize is that unfortunately, healthcare is not without its own bias. We enter into the healthcare conversation with a bias that is historically and socially constructed. And so you look at the history of public health and of healthcare, and we have these biases that unfortunately continue to this day, that we will address and work with different populations based upon what we understand. That is, again, societally and socially constructed, but again, is not necessarily biologically or public health constructed based upon data. So what I want to, the next couple of slides, again, just to lay a framework for Heleen and Amber to really focus on what really happens at the ground level. But here are the data. And I think these data are really important to look at from the standpoint of COVID-19 is a lens which has, if nothing else, really demonstrated that there were significant inequities in our system, both at a public health level and at a healthcare level. And so what I want to share with you, again, are these data that look at, for example, COVID-19, in this case, by race ethnicity for cases. And as you can see from this graphic, it is disproportionate number of individuals who are impacted based upon their race ethnicity. And again, looking at this slide, which is just a variation of what I just shared with you, you look at Native Hawaiian, other Pacific Islander population, Hispanic. These populations are, again, disproportionately impacted by cases. And then if I look at hospitalizations, not surprisingly, because oftentimes these individuals live and experience health at a very different rate from what other populations experience. We look at these populations by hospitalizations. And again, the same disproportionate marginalization exists within these populations. Native Hawaiian, other Pacific Islander, Hispanic populations, again, have been significantly impacted by COVID-19. I just referenced this, for example, to demonstrate that unfortunately, because of our data collection, we're seeing that these are populations that, again, are marginalized and have experienced hospitalizations as a function of their race. And then finally, the ultimate outcome, mortality. And you again see the same dynamic here. Native Hawaiian, other Pacific Islander, Hispanic populations, Black, American Indian, Alaska Native populations, marginalized populations historically, disproportionately impacted by COVID-19. Definitely, this pandemic, if nothing else, has really provided a light and shone a light on the disproportionality upon which health outcomes impact our marginalized populations. And finally, just a graph, I should say, just a table that demonstrates the the numbers here. And then the disclaimer that I like to share with these data is that, unfortunately, we're still missing a lot of data. They have not historically been required up until this past year. So for all these years in public health, we have not really focused and or required public health and or healthcare to input these data. And so for us to now acknowledge that this is important is but a reflection of the fact that over the last, decades, we've not really focused on this population as being an at-risk population. And then again, if you look at it from a vaccination standpoint, certainly the focus right now with respect to COVID-19, this is a framework that the Department of Health has adopted. These are the 7 priority areas that Department of Health has used to frame its access to vaccines. Success and or not success. Again, I think we could all question that. And then we've also used what's called the SVI, the Social Vulnerability Index, to determine how much vaccines get allocated to different communities. Importantly, before Department of Health started to roll out vaccination efforts, they did, thankfully, a lot of focus groups and conversations to look at what were reasons why people would choose and or not choose to get vaccinated. And these were a couple of the frameworks that they came up with. So again, wait and see mentality. Let's see about whether or not these are really safe vaccines. As I mentioned to you earlier, the concerns about historical trauma for our marginalized populations. Not surprisingly, health doctors and or other healthcare professionals are the most trusted sources of information. And then again, a really wait and see attitude, albeit acknowledging that this was something that they felt very obligated to do, especially to address those that they were concerned about their loved ones. Again, the equity strategy that Department of Health adopted, the 4 certain frameworks. And then just a couple of examples here in Spokane, a couple of months ago, it was great to see that the NAACP organized this group of African American leaders in the community to really speak from their perspectives on the importance of vaccination. And then down in South Central Washington, this organization looked at how to reach out to the Hispanic population on letting them know how and when to get vaccinated. This is just a graphic to show how, again, age groups of people vaccinated. You can see, not surprisingly, those who are most eligible, those who were eligible earlier are the ones who, again, we have the highest percentage of vaccination. And then again, although a little bit dated by about 2 weeks, we see, again, the variations based upon age. And then again, by race, ethnicity, not surprising, but again, important to see that there are definitely disproportionalities here. This was originally what Washington State used as a phased approach, albeit it's very outdated. And again, although I focused on race, ethnicity, I think we also have to recognize that there are other marginalized populations, such as those who live homeless, that have oftentimes been those who don't have voices and therefore are not necessarily ones who have a way to make their priorities known to populations. And so again, I think that when we look at moving forward, COVID-19 has definitely shined a lens on the fact that there are disproportionalities on how healthcare and public health gets played out. And I think at the end of the day, given the definition that I shared with you earlier, it's a collective effort for all of us. This is an opportunity for us to really move forward and really ensure that everybody has an opportunity to be healthy and to experience a positive health outcome. I'll leave it at that.
And just remind everyone that the chat is open to add questions. So we will have a Q&A session after all 3 speakers. So please add your questions in. Thank you.
Thank you, Dr. Lutz. So I'll kind of start back from here. But what I do want to really surface is that when we think about all the disparities and the data that Dr. Lutz showed us, is that these disparities among racial groups are not unique to public health. We see this in every single sector, and we're calling it something different. And without exception, we see this difference in the data. In child welfare, we call it disproportionality. In juvenile justice, it's disproportionate minority contact. In education, the achievement gap, and et cetera. We're calling it something different, but it's telling when we're seeing this in every single data set throughout all sectors. And to get an idea about how racism can impact health, at the very top of this graphic, you could change any one of the isms and we'll have the same impact, whether it's racism, classism, sexism, etc. And what happens is that we have a different access to resources and different living conditions. And if you add on top of that the racism that happens, it causes chronic disease, and with that, epigenetic changes and increased allostatic load, and lots of healthcare folks here. So epigenetic changes is the altering of the physical structure of the DNA methylation when exposed to trauma or chronic stress. And allostatic load is what we call toxic stress, the wear and tear on the body that accumulates as an individual is exposed to repeated or chronic stress. And from that, we see different chronic illnesses occur. And folks that have chronic illnesses were at higher risk and are at higher risk of developing COVID. And so for many years, we looked at, in public health and in healthcare, we really used what's called the medical model. And what we see here is certain behaviors and cause certain disease state and ultimately our mortality. And for a long time, we were like, if we just educate folks on what behavior we want them to do, things will get better, right? But what we found is that we really needed to start looking upstream. And when we look upstream, we can have a better idea about what is causing our behaviors. And so in this case, if we think of physical activity as an example, many people know we're supposed to be physically active, but what we now know is that it's our environment that can make it more conducive to being active. And we have to go more upstream. Well, who's making the decisions? It's that institutional power, the businesses, different sectors, schools, corporations, etc. And when we think about when those decisions or who those decision makers are, and at what lens are they making decisions with, that's when we start getting to kind of what Dr. Lutz said, those biases. It's harmful narratives that we hold about communities and assumptions that we hold about communities that can be damaging to their health. The COVID-19 pandemic has shed a light on existing health inequities. It amplified them and revealed their root causes. The inequities in hospitalizations and deaths, among other telling metrics, are the result of broader societal and structural factors like racism and other forms of oppression. And these factors result in different access to resources, services, opportunities, etc., including access to healthcare. And so if we look at it big picture, biased beliefs create policies and practices that impact communities. It impacts our behavior, ultimately creating a disease state or lack thereof, and ultimately death, unfortunately. So the conditions in which we live create consequences, and those inequities in conditions create disparities in consequences. And this image I created recently just to get an idea about what does it look like for COVID. And what we found is kind of what we call the upstream, downstream. A lot of health departments do it within Washington state and nationally. Where we looked, we saw a disproportionate impact among groups, different racial ethnic groups, similar to what you heard Dr. Lutz say, immigrant and undocumented folks, people with limited English proficiency, people living with disabilities, and people experiencing homelessness. And when we start asking, well, why? Well, they developed COVID. And if we ask again that why, what were the behaviors? Well, there were lack of behaviors. There was very specific public health guidance that we came out with that unfortunately, it wasn't really easy for many folks to do. And when we ask that additional why, we start looking at those very specific living conditions. And on this graph, we have physical environment, social environment, work and economic environment, service environment. And I would ask every single one of you to think of any one of these that didn't come into play with COVID. Healthcare, education, childcare, transportation, housing, experiences of discrimination, employment, etc. It all came into play. And when we ask that additional why, it's those institutional inequities, those policies and procedures that are in place that are making it really challenging for folks to have the behavior that we're looking for. And again, when we ask that last why, it's those narratives that are held and assumptions that are held about communities. And if we look at what needs to happen, yes, we still need, of course, we need emergency rooms, clinics, and we need that basic health education. But we also need to look at how do we have shared power? How do we share power with residents and folks most impacted and leadership? And how do we have an equity lens on those policies and partnerships that we're wanting to promote? And again, how do we change that narrative about what creates health and assumptions that are held in about communities? And I'll pass it on to Amber.
Hey, give me a second while I figure out the technology here. It's after my bedtime.
And while you're waking up, getting a cup of coffee, please remember to add your questions to the chat. And after Amber is finished, we'll switch to a
Okay, it looks like Ronnie was muted. I hope I'm not the only one who saw that. I'm going to go ahead and start talking with the assumption that you can see my slides and not my talking points. As I said, please give me some grace. It seriously is after my bedtime and I'm feeling a little loopy at this point. My goal is to share with you some insights from what Bob said and what Heleen said and put them together to make them actionable. What can we do now that we have this knowledge together? By the way, my name is Amber Lenhart. I use she, her pronouns. I used to work with Bob and Heleen at the Health District, formerly worked in Washington, D.C. at the Health Impact Project, and now I'm a freelance public health consultant in Spokane. And please bear with me for a moment while I recite some poetry for you to set the stage. If you're like me and you prefer your poems to rhyme, you will be disappointed. This poem is called, "Why is Jason in the Hospital?" Why is Jason in the hospital? Because he has a bad infection in his leg. But why does he have an infection? Because he has a cut on his leg and it got infected. But why does he have a cut on his leg? Because he was playing in the junkyard next to his apartment building and there was some sharp, jagged steel there that he fell on. But why was he playing in a junkyard? Because his neighborhood is kind of run down. A lot of kids play there and there's no one there to supervise them. But why does he live in that neighborhood? Because his parents can't afford a nicer place to live. But why can't his parents afford a nicer place to live? Because his dad is unemployed and his mom is sick. But why is his dad unemployed? Because he doesn't have much education and he can't find a job. But why? I share this poem to illustrate those whys that Heleen was talking about. But we can also look at Jason's ordeal from a national perspective. This chart compares life expectancy on the y-axis and health spending per capita on the x-axis for comparable nations. And the USA looks to be well below our expected outcomes based on our spending. I think we just aren't getting a good return on our investment in health. We place so much emphasis on the medical model and treatment. But what we know is that health isn't just what happens at the doctor's office, but it's in the places where we live, work, play, and gather. Oh, come on, slides. So like Heleen mentioned, we all know the importance of healthy eating, but fast food swamps with cheap, easy options make that challenging. It's one thing to keep prescribing someone with albuterol if they have asthma, but if they live in housing that has poor indoor air quality because of mold or pests, that inhaler isn't going to do you a whole lot of good. Same with whether we're exposed to healthy foods in early learning. Do we have access to quality early learning at all? Can we get physical activity in the places where we live, or are we jaywalking across 7 lanes of traffic like this poor fellow in the bottom right? So these are all illustrations of determinants of health, and COVID-19 provides a nice specific example for us to walk through. Bob shared some really specific data. These are old slides, but specific data to illustrate some of these health inequities that we see in COVID. And Heleen pushed us to think outside of the biomedical model and consider how the socio-ecological model, policies, and community level factors influence inequities. So what shapes inequitable health outcomes? I like to use the metaphor of a tree. If you've seen me talk before, I always talk about trees. I don't know much about tree science, but I have noticed that the leaves of a tree can tell you a great deal. As we view a tree's canopy, we can learn about the health of the tree. Might it be infected with pests or disease? We can learn about the health of the roots. Is it getting enough water? Too little, too much? Are there enough nutrients in the soil? What about the groundwater? All of these have to work together as a system to keep the tree healthy and lush. And when we apply this analogy to health, we can understand more than initially meets the eye. Let's imagine that the tree's topmost leaves are our indicators of health conditions. Those conditions are influenced by circumstances and behaviors. Heleen mentioned the 5 whys and asking what causes that. Why might someone smoke or eat unhealthy food? Well, as I said earlier, factors in those places around us, community, infrastructure, and environmental factors influence those decisions. Household finances, culture, and other socioeconomic factors determine which neighborhood we live in, which school we attend. And why do some people have different socioeconomic situations? What's policies and systems? And of course, we have our groundwater, Heleen mentioned. We've got these biased beliefs, these isms that infiltrate all of our systems. The takeaway here is that it's these root causes that are most important. So if we walk through COVID-19 as an example, so why might we see some of these examples? Let's imagine a person who has now been hospitalized or potentially passed away from COVID-19. Why did this happen? Let's ask some whys. Why did they even have COVID-19 in the first place? Well, maybe the people around them had to go to work while they were contagious. Maybe they lived in a crowded or multi-generational household. Well, why was that the case? Potentially there were workplace policies that actually didn't encourage them to stay home when they were sick, but rather encouraged them to go to work while sick so that they could get a paycheck. Or maybe they had to work 2 jobs just to cover the rent. And so they might have missed one job for COVID, but then been able to go to their other job. The cost of housing maybe is a challenge for them. Perhaps it's just their culture that you show up, you go to work. Or maybe what we found out with some populations like Pacific Islanders, that just access to unemployment, people from the Marshall Islands just weren't able to access federal unemployment benefits, leading some people to go to work while they were contagious. So why was that? I mean, it was these socioeconomic factors, the neighborhoods people lived in, their employment status, their educational attainment, all shaped by different policies and systems like I mentioned COFA, or the housing policies, school discipline policies that prepare some students for success, but put others on the prison pipeline. And of course, we know that our groundwater is just contaminated with these isms, racism, classism, and xenophobia, that wherever we look, these isms have infiltrated our systems and cause health inequities. I like this metaphor of a tree because I think that you can use it to look upstream or down the trunk. You choose your metaphor that you prefer, but to see that if we were to change something closer to the ground of the tree, closer to the roots, that it would have a ripple effect through the branches and the canopy of neighboring trees. that really it's these roots down here that are the most critical for our action. In essence, just stating that it's really policies and systems that shape these inequitable health outcomes. And the key takeaway is that we can eliminate health inequities by changing those policies, systems, and environments that create them when we bring health equity into the conversation. So what does that look like? How do we change this, and how do we start talking about health equity and start improving the policies that currently create health inequities? Well, we can ask for health equity impact assessments and other approaches to apply a health lens to policies. There are researchers in the city, the state, and across the nation who do these assessments that use scientific data, primary data, secondary data, literature review. Maybe they talk to people in the community, take scientific data and community voice and share that with community decision makers to help them weigh the trade-offs of their decisions and make better decisions for health in sectors like transportation or criminal justice or housing. We can continue to educate our decision makers about the ways that those policies do impact health inequities. How is housing related to COVID-19? How are criminal justice or educational policies associated with some of these COVID-19 inequities that we're seeing? We can help our decision makers make these connections so that they can be more informed when they are making decisions. You can educate, advocate, and if you're allowed to do so, lobby during the session, which I believe is now over, for health equity promoting policies, systems, and environmental changes. And of course, I think most critically is amplifying the voices of people with lived experience as experts, the people who really truly understand what their needs are, what the barriers are to good health, and exactly what they need to thrive. So I would just basically leave it there. I don't have a whole lot more to say to you, but I would challenge you to think about this tree in your work and in your activities. Where is your work? What policies and systems are upstream from the issues that you see or you're facing with the people that you work with? Potentially, how could this kind of an approach, looking upstream or down at the roots, change the work that we do or the impact that we have? Where are we working on the tree? And if you could climb elsewhere on the tree, where might you go? All things to just consider. So with that, I will thank you for bearing with us, tired folks, at the end of the night. And I believe pass it back to Ronnie once I figure out how to stop sharing my screen.
Thank you all so much. Those are hard factors to look at, but it's really good to see that there is work going on. So thank you all for sharing that information. Let's take a minute for Peter Lucas to give us a little bit of information about Healthcare for All's activities, and then we'll move into Q&A. So Dr. Lucas, can you unmute yourself and take over?
I'm Peter Lucas. I'm a practicing physician and board member of Healthcare for All Washington. And I think most of you are probably aware of who we are and what we're about. And our mission is primarily to establish a single payer healthcare system in Washington state. We figure we probably can't wait for the other Washington to pass Medicare for all. So in the meantime, we're trying to establish a single payer healthcare system in our state. We've been in existence for about 20 years. And we've had some successes in the legislature over the past few years, including helping to write and advocate for a bill to make insulin more affordable for Washington residents. That bill was passed and has really produced good results for diabetics. And we were instrumental in developing writing and developing a legislation to create the Universal Healthcare Work Group, which met throughout 2020 despite COVID. We had, I think, seven members of our organization on that work group, and they came up with 3 plans to establish universal health care in Washington State. One of them is possibly single payer. So that group has now morphed into the Universal Health Care Commission, and that bill is sitting on Jay Inslee's desk, and we're hoping he'll sign it soon. And we want to have a real presence on that board, on that commission. So we used to have a lobbyist who no longer is with us, but who can come back and lobby to have some of our members and some single payer advocates on that commission so that we can possibly get a single payer healthcare bill passed in Washington State. So we'd like to hire her back to do that. But we need your help in order to do that. We need some financial support. And not only for her, but also for our communications specialist, who's our paid employee, and to help support our efforts like these webinars and other outreach efforts. So we're asking you tonight to make donations to our organization. One-time donations are fine. We're certainly encourage monthly recurring donations as they help us to continue going throughout the year. So you can go to our website, healthcareforall.org, and just click on the donate button and make a donation. We would very much appreciate it. And thank you for listening.
And so now if I could ask Gary to unmute himself, and Bob and Amber and Heleen, if you've turned off your videos, turn them back on. I'm actually having trouble trying to figure out how to pin you spotlight. That helps. See if I can spotlight everyone. No, I don't think I can. And spotlight. Hey, it's working, it's working, it's working. And one more. What did I do with you, Heleen? Oh. I'm not seeing you. There you are. It worked. So Gary, do you want to go ahead and start with questions?
Yes, thank you, Ronnie. And thank you to all of our presenters. I think that was really important information. We do have a number of questions from participants. And I think a wonderful question to start off the discussion tonight. It cuts to the heart of everything that we're trying to do, health for all. And that question for us is, let me get to that here. Is single payer healthcare financing an essential component for eliminating racism in healthcare? And I would add to that, why? So I'm just going to go around the screen and ask that each of our participants answer that question again. Is single payer healthcare financing an essential component for eliminating racism in healthcare? First, on my screen, Amber.
You're supposed to go in alphabetical order by last name. Sorry. Yes, I think I'm going to say yes. And here's why. Because to the extent that our health inequities are driven by disparities in social determinants of health, I believe that a lot of the lack of return on investment that we see in health is that we aren't putting our money in the right places. And if we were to invest in social determinants of health, that we would have better health outcomes. For example, there's a program that serves like the South Jersey, Greater Philly area, that they recognized that folks who are diagnosed with terminal chronic conditions, renal failure, cancer, are typically placed on special nutritional diets to manage their condition, but that people might have might have barriers to getting that quality food. They might not be able to even stand up in their kitchen long enough to cook themselves dinner. So this group called MANA started providing meals to people in the region, 3 meals a day, no cost, 7 days a week, to help them manage their health conditions. But these things have a return on their investment. They're saving money. These people who get their meals through MANA have shorter hospitalizations. They have lower medical expenses. But these things have to be reimbursable by health insurers. Health insurers have to be contributing money to addressing the social determinants of health. And until we have a system that does that equally for all people, regardless of whether you have Medicare or Medicaid or Kaiser or whatever, that you can have those things covered, then I will say yes, we need a universal single payer system.
Wow.
And soapbox.
How about you?
Yeah, I mean, I think Amber said it very nicely, Gary. I think that, you look at our system, and if you look at, again, I think Heleen can really speak well to this, but we have a system that has been structured based upon defining inequities and perpetuating those inequities. And until we really address that, then we'll continue to just perpetuate the problem. So I think that, this again, as you suggested, this payer system would really sort of level the playing ground. I think it's just, again, it's unfortunate that our society, and especially the impact that, or the input that healthcare has had, has really created a very unlevel playing ground for everyone. And so again, until we realize that unfortunately our society has a lot of inequities baked into it, and a lot of it is financially driven, until we really address that and acknowledge that healthcare is not a privilege, it's a right, then we will continue to have these problems going forward with respect to health outcomes.
Okay. Heleen, you get to summarize it.
And I mean, I would echo exactly everything that Dr. Lutz and Amber have mentioned. I think it's an essential factor to eliminate racism in healthcare, and there are many others. Again, I think it's addressing those harmful narratives about what creates health. But it's also, when we look at I think in my bio, it was mentioned that I'm an enrolled citizen of the Turtle Mountain Band of Chippewa Indians, and I grew up on a reservation in Northeast Montana, and all my family still lives up there. And so I grew up with Indian Health Services was my healthcare. I'm on the local board for Urban Indian Health Services at Native Project. And one thing that we are really pushing is, how do we have providers that look like the patients that are coming in, to truly understand, so we could see ourselves in the healthcare system, that we're just not a user of the healthcare system, but we are part of the healthcare system because we're providing that service as well. And again, we'd have to reassess the education system then at that point, and looking at how discriminatory practices or inequities are played into even the education system. So I agreed with everything that they said. I think there's just so much more to it to address racism within healthcare. It's really understanding who our patients are. One thing that became very evident this last year, and has always been an issue, is even folks living with limited English proficiency, and how do we ensure that we're doing our due diligence to make sure we're following the federal law, Title VI, providing translation services to folks when they need it, and not just, virtually, but how do we ensure that we're hiring people that can serve their community, cultural navigators, community health workers, whatever it is we want to call them, but that they're also within the healthcare system.
So it sounds like it's not just an essential part of ending institutional racism within healthcare that we have a single payer type of system, but that there are a number of other steps, even once you've got such a system, that are going to be essential to move us forward. So there are a few other questions, and I know that we are, Ronnie, can you just confirm with an up or down? Do we have 9 more minutes? 5 minutes?
Finish it in 5 minutes and we'll just wrap everything up at that point.
Okay. We have 2 questions that I'm going to try and combine because they touched on similar subjects. The question was asked about housing and how it is that we don't recognize the importance of housing. So, for example, farmers and their families are forced to live in really suboptimal housing. How do we protect housing, looking at it from this healthcare lens? And similarly, and I think that this question actually touches on part of the answer, there was at one time mobile health that went into neighborhoods offering shots, showers, wound care, education. Do these currently exist around the state? And it seems like both of those are touching on that need for the local presence. But let me go in reverse order. Heleen, could you respond to those questions about that need for the local presence, housing, and mobile clinics?
Yeah, I think, again, I mean, COVID is such a great example. I mean, I don't want to say what a great, but a very relevant example of where those basic access and where we're getting access to healthcare are so important. But thinking about housing and how housing, it's a determinant of our health. It's one of the most important aspects of our health outcome. And it's very essential. And so I think where we sometimes are challenged with housing is we have sometimes the same players at the table, right? And when we are looking at solutions to our housing crisis, how do we engage folks that, again, are most impacted? And when you look at Amber's tree, if we gathered the data for all of those areas, we're going to start to connect the dots and make connections. And how do we use the data to drive some of the decisions? If we start to disaggregate who has access to housing, who are homeowners, who are most evicted, it's going to tell us what we need to do and where to focus. And it is really, how do we engage the folks that are most impacted to have a better idea about what those solutions are? I've heard so many times this last year, folks who are closer to the problem are also closer to the solution. And it's really, how do we engage folks and how do we share power? Because we're not doing that. We're not sharing power. And I speak from a public health perspective with positional power that we can do better. We can do better to have an understanding about what needs to happen. We're very smart, but we're not smart enough.
Thanks. Bob?
Yeah, I mean, Heleen, well stated. Yeah, I think, Gary, it's Maslow's hierarchy. If you can't essentially provide those basic requirements for living, it's very difficult to really move up on that hierarchy. And so again, it's also what in public health, we talk about the social determinants of health, and housing is one of those. So yeah, it's a challenge because obviously it's a structural issue. It's one that we don't necessarily recognize or acknowledge. But again, until we recognize and acknowledge the fact that this is a fundamental need for every human being in our society, it's for them to achieve health, then we're going to continue to struggle with the adverse health outcomes that we've been dealing with from both a health standpoint and a public health standpoint.
Amber, final say on that topic?
I don't know that I have much to add. Yes, I agree entirely with what was said, and would just reiterate what Bob's point, that we can't expect people to survive, let alone thrive, if their basic needs aren't aren't met. So it's so critical to make sure that people have housing and feel safe and have access to food before we can expect them to be thriving after COVID or not using substances, having good mental health outcomes. Like we just have to see people as valuable humans and meet their needs when we see them.
All right, Ronnie, I'm going to take moderator's prerogative here, ask the final question. Each of you will have 30 seconds to give that elevator response to the most pressing question of the day. What is one action to combat health inequities that gives you hope? So Bob, how about if you start that one? 30 seconds.
Thanks, Gary. Well, 30 seconds. Yeah. I mean, again, I go back to my definition. Health is what we as a society do collectively to assure the conditions in which people can be healthy. It's our responsibility to provide the environments. And until we acknowledge that it is a requirement, not just something that is a privilege, then I think we are going to be challenged as a society to truly experience health.
Okay. Amber, one thing that we should be doing that gives you hope to combat inequities, health inequities.
One thing that I see on a daily basis that I see people doing to combat health inequities without even realizing it, that just blows me away and gives me so much hope, is when people encounter other people and instead of seeing stigma, they see curiosity. They're curious and they ask why. The more we can ask why and see each other with curiosity and not judgment and stigma, I think the better we can serve each other.
Thank you. Heleen, can you take the last stab at it?
Sure. I think one thing that we could do that gives me hope is let's get comfortable being uncomfortable. Let's sit in uncomfortableness about how to address racism within our personal lives. It doesn't go away when we're not working, and try to understand better as individuals how it plays out in our life too.
Thank you. Thanks to all of our speakers. I turn it back to you, Ronnie.
Well, thank you all very, very much. These are really hard issues to address. And just like you were just commenting, we really need to face them. So thanks for making them so clear for us. You've given us some powerful suggestions to offer solutions and to show what's happening in different parts of the state, especially your part of the state, Eastern Washington, and pointing out that it's not going to be a medical solution alone. It's not going to be just looking at the social determinants of health alone, but it's also looking at political action that we can take to make these differences. And I think the comment that the people closest to the problem are the ones with the best solutions to the problem, I think that's a sign or a message that we can close with, that we all need to take to heart. Healthcare for All Washington is looking at ways to make these, to pull these social and medical and political determinants together. So please support us. Thank you very much to Bob and Amber and Heleen, and to you, Gary, to everyone that participated tonight. So thank you all very much. And please join us next month. We have a public meeting planned on June the 9th, the second Wednesday in June. We have a couple legislators. Emily Randall has agreed to come. We're waiting to hear from more to help give an overview of the solutions. So again, thank you all very much for your participation, and to everyone who joined us tonight. Thank you, thank you, thank you.